It's estimated that probably 10 million people in the U.S. are currently diagnosed with osteoporosis. And my sense is that's probably underestimating the prevalence of that disease. We know from just the overall demographic and risk factors that about 34 million Americans are at risk of developing osteoporosis. And as I mentioned earlier, of those, about 1 in 2 women age 50 will have a fragility fracture in their lifetime. Currently, we see about 300,000 admissions for hip fractures in the U.S. each year. And our fragility fractures, and I'll talk a little bit more about what fragility fractures are, but hip fractures are, from a health standpoint, the most impactful type of fragility fracture that we see. What's surprising, and I think a little bit alarming to me as a healthcare provider, that of those patients that have hip fractures, about 85% of them aren't getting treated for their underlying osteoporosis. And that's true in our own statistics. When I looked at our population at the Med Center, the vast majority of people that have a preventable condition that have come in with something as significant as a hip fracture aren't getting the appropriate treatment for the underlying problem, which is the osteoporosis. So I want to give you just a high-level understanding of some of the impact of osteoporosis. One thing to be aware of, we're an aging demographic, and so we're seeing an increased prevalence of osteoporosis. And this is an older article from 2014. Look back at 2010 data from healthcare claims data and saw that there's about 10 million people with osteoporosis. Reflects back on the statistic I gave earlier, and projected that there'll probably be 30% more, 13 million people with osteoporosis in 2030. As I said, I think that's probably a very conservative estimate to what we think the growth and prevalence of osteoporosis is likely to be. It has a huge impact on healthcare delivery and the overall cost of healthcare in the U.S. Looking back again at claims data in 2005, it was about $19 billion that were spent on treatment of osteoporosis and fragility fractures. And that pretty much doubled by 2018 to just shy of $60 billion. And the projections are that that's going to increase to $95 billion by 2040. I would say with some of the more expensive osteoporosis medications we have, that this is probably way underestimating the impact from a healthcare standpoint on the cost of osteoporosis within our population. A couple of factors that are leading to higher costs. We have an old aging demographic, the average patient that we're seeing in our healthcare system. They're getting older and older. We underdiagnose osteoporosis. So as I mentioned in the opening slide, most people with osteoporosis aren't aware that they have that underlying condition. It's really kind of a silent epidemic. There aren't any symptoms from osteoporosis until you fall and you fracture something. So the fracture is usually the signal event that you have underlying osteoporosis. And then also the undertreatment of osteoporosis. As I mentioned, the patients that have a fracture, that have clearly underlying osteoporosis, the vast majority of those aren't being treated for that condition. So just kind of to give you the impact, when we look at just the hospitalization costs for osteoporosis, it's pretty significant. So when we look at here the cost of fragility fractures, and this is just dealing with those that are hospitalized. A lot of fragility fractures, particularly spine fractures, for example, we don't hospitalize patients for that condition. But it's a little over $5 billion that we see costing us in 2025. This is just based on kind of current projections where we're at presently. But compare that to some other conditions which we think have significant healthcare impact. So for example, breast cancer. We do far better screening for breast cancer than we do screening for osteoporosis. And cardiovascular events, which are major impact on our healthcare system, heart attacks and strokes, still are less than what we spend annually on the hospitalization for fragility fractures. So there is a lot of healthcare resources and expense going to care for these fragility fractures. So just to kind of give you an overview of fragility fractures, we define fragility fractures as those coming from low impact injury. Generally what it reflects is fall from standing. So kind of the impact that your body would take falling from a standing height. So we're not talking about the type of fracture that we get if you were in an automobile accident or you fell down a flight of stairs or you're by baseball bat or whatever. Those you kind of expect. Even normal bone might fracture under these. But what we're looking at are bones that fracture with relatively low amounts of force being applied to them. And we can also tell fragility fractures from the location. These have very characteristic, not only the history, fall from standing, but also the type of fractures that we see. Probably the most common fragility fracture that we see are fragility fractures of the spine. And they typically occur in the lower thoracic spine kind of in the back of your chest, and the upper lumbar spine, kind of at that junction, are very characteristic. And what's surprising is the vast majority of these go undiagnosed. In fact, they may not even have much in the way of symptoms. One of the things that we look for osteoporosis is, are you getting shorter? Now, you get shorter for a variety of reasons. Some is the soft material between your vertebral bodies, the discs, dry up over time, and they shrink, and that leads to some loss of height. But if you lose 2 centimeters, or about an inch of height, that's an indication that you might have underlying osteoporosis, because you're getting just these low, slowly developing compression fractures of your spine. So those are typically asymptomatic, and we don't pick them up until maybe you go in for imaging and say, oh, by the way, did you know you have compression fractures in your spine? So they're not, oftentimes not clinically significant from the standpoint of the patient looking at them. They can come from minor falls. In that case, oftentimes you have point tenderness, but we don't oftentimes treat those. We do have treatment for those types of compression fractures. We actually go in and put cement into the vertebral body and keep it from collapsing further. It's called vertebral body augmentation or kyphoplasties. But those are for the ones that are highly significant, and that's only a small fraction of the vertebral compression fractures that we see. I would say those are the most common fragility fractures that are there. The ones that have the most clinical impact, both on the patient, and we're going to talk a little more detail on this, are hip fractures, which are fractures of your proximal femur, the bone that runs in your thigh. And that's particularly in the older population, the more elderly population. The hip fractures are the one that have the biggest impact, both in healthcare costs. And then distal wrist fractures, or distal radius fracture. Those typically occur in a slightly younger population because the common mechanism for that is a fall on an outstretched arm. And so typically those are patients that are more active, they tend to be a little bit younger. Same thing with more proximal humerus fractures, fractures of the shoulder. Those are also fragility fractures. They can occur again from a fall on an outstretched arm, but tend to be more active type individuals. So the characteristic thing of the fragility fractures are that they're really low impact type injuries that are leading to fractured bones. Our models based on kind of where we're seeing fragility fractures and the demographics suggest that there'll probably be more than 3 million fragility fractures in the U.S. As I mentioned, a lot of these are asymptomatic, so a lot of them we don't know about. And I would say the most important part about a fragility fracture, particularly like those spine fractures, is that they are the best indicator that we have that a patient's likely to have a subsequent fracture. So if you've had one of these asymptomatic compression fractures, you have about an 85% increased risk of having a more significant fragility fracture down the road. So that's one of the things. That the best indicator for a future fracture is a past fracture. And as I mentioned, studies that are looking back on treatment find that the vast majority of these patients that have had fragility fractures aren't getting appropriate osteoporosis medication in that period following the fracture. So talk a little bit about hip fractures. And as I mentioned, of all the types of fractures that we have, hip fracture from a healthcare standpoint has the most significance. And the one thing I don't think people are aware about, that 20% of people that have had a hip fracture die within a year. And it's not that they necessarily die from that fracture. Some do. There are complications from hip fractures, things like a pulmonary embolus and being bedridden that can give rise to actually mortality directly related to the hip fracture. But it's more often an indicator that suddenly a patient is reaching a stage of fragility, where they really start to have a lot of other confounding healthcare factors. So as I mentioned, hip fractures tend to occur in the older population of elderly. They tend to be associated with patients with other underlying medical conditions. And that process of being laid up in bed, healing from a hip fracture, leads to further bone loss, leads to further muscle loss, leads to other complications from their other underlying conditions. And so there's an insignificant increase in mortality having hip fracture when you're older. As I mentioned here, mortality rate increases about 6-fold for patients that have had a hip fracture. Also, it has big impacts on lifestyle and care. So about 2/3 of patients that have had a hip fracture don't regain their prior level of function. So it is a life-changing event from that standpoint of things that they were once able to do. Yeah, Jack?
Oh, I was just going to ask, are hip replacements normally because of this?
They are a cause of hip replacement, so some hip replacements are done. Also, we were something called hip arthroplasty, where hemiarthroplasty will only replace half of the hips. They are all treated surgically for the most part. There's some in a very elderly population where they don't necessarily get treated, but for the most part, these are all surgical cases. And hip replacement is one of the types of treatments that we have for fractures.
So why are healthcare providers not taking the lead on this?
Well,
that's a huge percentage.
it is a very alarming statistic. I actually have a section, I'm going to get to that, because
Oh,
I think
cool.
that is something that we need to be thinking about both as healthcare providers, as patients. And I think part of it is that general lack of awareness. But I think that's a really important issue, and I want to spend some time talking about that. So that loss of function we mentioned comes with that loss of independence. So almost 2/3 of patients that have had a hip fracture lose their ability to live independently after that, and then have to move into a care facility. So just that impact of having that hip fracture has significant life-changing effects, both in the case of mortality and also the morbidity associated with a hip fracture that's going to have long-term consequences on their lifestyle. So now comes the biologic part of the talk. I'm going to talk a little bit about your bones and kind of what's driving the osteoporosis. And I want to do that kind of as a lead up to some of the treatments and diagnosis that we have for it. So I think oftentimes we think of bones, we kind of think of like what you see in a museum. This looks like a piece of wood, it sits there, and we built it, it stays there. And that's not the case. The bones are a very metabolically active tissue in our bodies. They're constantly changing, they're constantly being remodeled in response to the forces that we apply to them. And so I mentioned if we look at the bone, the inside of that bone, where a lot of this activity happens, it looks like this complex mixed array of little bony struts that are all tied together. And one of the things that's remarkable about this is that architecture gives a bone a lot of its strength, a lot of its material properties. It also makes it relatively light. If we put replaced our bones with stainless steel, they'd be a lot heavier and not that much stronger. So it's that architecture of those struts that gives the mechanical properties of the bone. And what's interesting is that if you go out and change your activity, you decide you're going to take up running, or you're going to do some type of activity, you start to put more forces on the bone. These little architectural struts within are constantly being remodeled in response to those forces. So you increase your activity, you start to remodel that bone in relation to that activity. If you lose side, you're going to become a couch potato, you start to lose some of that bone. So it's a very fluid, dynamic structure that gives rise to this architecture. And there's really two big cells, we'll talk a little bit about that are responsible for that remodeling. There's one set of cells we call osteoclasts, and they go in there and they resorb the old bone, the damaged bone, and they're constantly kind of chewing up that bone, releasing calcium. Some of it is, we need calcium in other organs to live, and the bones are the major source of calcium. So we use that as kind of our internal reservoir for calcium, and these osteoclasts respond to that need for calcium and break down the bone into its constituent structures that are within the bone. And then there's also cells that form new bone. So I kind of think of it like, when you repave the road, you have the first thing that comes through and chews up all the macadam and breaks it up, and you come back, you put a new layer of macadam over top of it. Well, these osteoblasts are that cell that comes through and puts a new layer of bone down. So you have this nice balance of bone resorbing cells, your osteoclasts, and your bone forming cells, osteoblasts. And it's the balance of these two structures, that catabolic resorption of bone that happens with the osteoclast, and the anabolic forming of bone with the osteoclast. And that's the healthy balance that occurs for a very short period of our lives. So if you think about what happens with aging, as we're developing, and growing, our osteoblasts are working faster than our osteoclasts. We're adding more bone, we're constantly kind of building that up, and that happens from birth up to about age 30. So about age 30 to age 40 is the most amount of bone you're ever going to have. And so a lot of what we do during our youth and our adolescence kind of sets that level, how much bone you're going to have to work with. Because after age 40, it's all downhill. Hate to say it, but we just don't make as much bone after age 40. A lot of reasons for that. One is as you get older, your cells and osteoblasts are like that, just don't work as well as they did in the past. But there's some other factors that are really important. And one of the key ones is the effect of our hormones because the hormones are a major stimulant for those osteoblasts, and particularly estrogen in women. So postmenopausal women are at risk for osteoporosis because they lose that anabolic, that stimulating effect of the estrogen on those osteoblasts. So they're not making as much bone as they get. Loss of testosterone in men is also a factor. We mentioned aging, and that's just the effect of aging on our cells. They just don't work as much. A couple of the other important things are the lack of mechanical stimulation. So if you become less active in your elderly years, the bones, you're responding to that mechanical stimulation. So if there's less stimulation, there's less bone formation. And so that balance tips more towards bone resorption and away from bone formation. There are certain types of drugs that we give to patients that can really impact this balance. The big one is steroids. So a lot of times patients that are on long-term steroids, say for asthma or rheumatoid arthritis or other conditions in which we give steroids to calm down the inflammation, also have a big impact on bone health. It can lead to weakened bones. And then there's other dietary factors, vitamin D, calcium are two big ones, that if we're not getting enough of the materials necessary to form bone, that causes this imbalance where we see more bone resorption than we see bone formation. And so that curve drops at a faster slope. So as far as risk factors for osteoporosis, things that we know are going to impact. I mentioned one is being a postmenopausal female. Not a lot that we can do about that, but that is one of the biggest risk factors. There's also genetic impacts, so ethnicity is common, particularly if you're from more Northern European ancestry, tend to have higher risk factors for osteoporosis. Family history comes in that, so if you have a mother or a grandmother that had osteoporosis, there is an underlying genetic association you're going to be at higher risk. We talk about BMI or body mass index, oftentimes from the standpoint of thinking about obesity, but the other end of it, if you have a low body mass index, you're putting less force on your bones, and you generally have lower bone mass to work with. So a low body mass index can be with that. A low level of exercise, so your bone health is tied to your muscle health. The muscles provide a significant source of mechanical stimulation on our bones. So as you age, you also lose muscle, and so that loss of stimulation can impact your bone health. But overall, a lower level of exercise is a significant risk factor for osteoporosis. And then certain habits that people may have. So smoking and alcohol use are both associated with a higher risk of osteoporosis. Well, some of it's the direct impact that they have on the cells themselves. Some of it's related to the impact it has on the blood supply their ability to provide nutrients to the bones necessary to make new bones. And I mentioned medications. The impact of steroids is one that we see quite commonly, but now we're starting to see osteoporosis in patients that are cancer survivors. So it's particularly things with like lymphoma, where we give patients very high dose steroids and alkylating agents, both of which have a direct impact on the stem cells that form osteoblasts. Those patients can be at significant risk for osteoporosis. So one of the things kind of as we manage these patients in their post-cancer life is that we have to manage the impact of osteoporosis. So the osteoporosis in that population is becoming a significant risk factor that we're looking at. And then there are certain diseases that are associated with osteoporosis. So particularly inflammatory arthropathies like rheumatoid arthritis, both from the standpoint of the inflammation around the joints leads to a resorption of bones. Also the medications that we give these patients can lead to osteoporosis. And then other diseases that can directly affect bone health. Hyperparathyroidism is one that we see because hyperparathyroid hormone is one of the main ways the body controls that resorption and formation of bone in your body. So that's a significant one. And then diabetes is kind of unusual. It has multiple effects on our bones. One is it affects the blood supply of the bone and makes it less able to form bones. It also has a direct impact on the underlying architecture of bone. In osteoporosis, we focus a lot on the mineralization of the tissue, but there's also this collagen infrastructure that's in there. And diabetes seems to make that collagen framework. It's kind of like the reinforcing rods in concrete. That's what this collagen forms. But in diabetes, that tends to be more fragile and brittle because of the impact of glucose on that collagen structure. And that can make bones, those bones in diabetics oftentimes are more inherently brittle than we see in normal bones, even with the same amount of mineralization. So diabetes has multiple impacts on bone health. It's a very common condition that can be associated with increased risk of fragility fractures. So how do we diagnose osteoporosis? There's a lot of things that we can use. One of the things that's very helpful is just kind of using some of the demographic data that patients have to predict a risk for osteoporosis. And there are several out there. FRAX, you may hear that term called, is one that's commonly used. And that takes a couple of kind of factors in and puts them into a calculator, and then we can calculate what the risks are. And we actually use that to identify patients that ought to be screened, and in some cases they need to be more aggressively treated. And they really focus on those factors that we've already talked about. One is age, looking at weight, use of estrogen, race, and some of those genetic factors. Race is the one that's looked at here. Rheumatoid arthritis, the risk factor, and then any prior fracture of the spine, hip, or wrist, those fragility fractures. And you can take those numbers, you can apply a score to it, plug it into that calculator, and you can estimate what the risks are. And there's several of these. Some of these are available online. You go to the National Osteoporosis Foundation. You know, these you can calculate kind of what your risks are just simply by plugging in some pretty basic numbers that you may have. One of the ways that we also look for osteoporosis, and this is the kind of the gold standard, the definitive way by which we make this estimate is through something called DEXA, or dual energy X-ray absorptometry, which is we put X-rays through the body. These are very low dose X-rays, so much less than what you would have if you were getting an X-ray to look at a fracture. But we can measure the differential absorption of it, and from that we can calculate a bone mineral density. It tells us how much of the hard mineralized bone is present, and we look at the spine, we look at the proximal femurs and the femoral neck, and then in some cases we'll look at the distal radius to get an estimate of that. And then what we do is we compare individual patient results to standardized databases, and I'll go into a little bit more about how to interpret those DEXA scores for those of you that have had DEXAs to understand what the risk factors are. So the U.S. Preventative Services Task Force recommendation is one of the overarching entities that provides guidance on what screening exams are appropriate. And if they determine then that they are appropriate for healthcare, they're typically covered by insurance. So it's important to kind of have that the U.S. Preventative Service Task Force recommendations for that. And currently they're recommending that DEXA is approved for all patients 65 and over. And then there's a population, a younger population, if you have got some of those demographic scores that say, hey, this patient's more at a higher risk for osteoporosis. One could be that you've had a prior fragility fracture. You might be 50 years old and you've had a distal radius fracture or compression fracture of spine. You're at higher risk. Some of the scores from that calculator may indicate that you're at higher risk, and that would justify getting a DEXA scan at an earlier age. And then there's other professional societies that are out there that provide their recommendations for those. Most of them would recommend that men also be screened for osteoporosis at a later age, after age 70. And then people that are under, that have had a fragility fracture, or same thing with men that may have had higher risk for osteoporosis, that they would also get regular screening with DEXA. So when you get your DEXA result back, you'll see that there's two scores on there. The one that we focus most on is called the T-score. What this is a standard deviation between your result and the standard deviation that we see in that young, healthy population, age 30 to 40, when you have your maximum amount of mineralized bone. So if you're a young, healthy adult, you expect that to be similar to other young, healthy adults. That would be a T-score of 0. And anything from 0 to 1 standard deviation lower than that is still considered healthy. What we start to worry about is when you start to get less than 1 standard deviation of your normal bone, and that's from -1 to -2.5, you have bone loss, what we call osteopenia, or less bone. And then greater than 2.5 is when we fall into the diagnosis of osteoporosis. Now there's some patients that have had other factors. They may have more than 2.5, but they may have had a prior fragility fracture. So if you have bone mineral density of the T-score -2.5 and you've had a spine fracture, a hip fracture, you have established osteoporosis. You have, in that case, sometimes severe osteoporosis. It means you need to be aggressively managed in that condition. The other one that we use, particularly, this is used more often in patients that may be having certain treatments, things that have been affected bone mineral density. They may be 30 years of age, and that's the Z-score, and that's what we use to kind of compare a young, healthy adult to somebody who is young, relatively healthy, but may be at risk for bone loss. So it's the T-score that you really want to focus on, and that's what we use for guiding treatments. So we'll talk a little bit about the treatment for osteoporosis. So we talked about that balance of bone resorption and bone formation, and that's really what the treatment is focusing on, either reducing the rate at which bone is being resorbed or stimulating new bone to be formed. And so the anti-resorptive drugs, they focus on those osteoclasts, really trying to slow them down. And that's the older form of osteoporosis treatments that we've had for about the last 20 years. And those are primarily the bisphosphonates. They've gotten some attention in the literature because we were concerned about some atypical femur fractures that can occur with that. You can get a condition called osteonecrosis of the jaw. All of these sound pretty terrible, and for those that get them, they can be bad conditions. They're relatively uncommon though. And we see those sometimes with bisphosphonates. And part of that is the reason that bone resorption is part of the normal bone remodeling. So if you shut that down, in some areas you start to weaken the bone itself. But one thing I would just say with these anti-resorptive agents is they basically take you where you are at a point in time and hopefully try to keep you there. You're just preventing further bone loss. You're not really stimulating more bone. You're not doing a whole lot to decrease your fracture risk. You're hopefully reducing your risk of future bone loss that's going to tip you into a higher risk state. So they have a role, and they're really the first line treatment for patients that come in with osteoporosis but maybe haven't had a hip fracture. You just identify them at the rate at which you're declining here in your bone mass puts you at risk for for getting a fragility fracture. So we mentioned the bisphosphonates; those are the kind of frontline therapy. We have other ones that are more aggressively treat inhibiting the osteoclast. Prolia is one that we use. In that case, that's a sub-Q injection. And then there's some hormone replacements. We typically don't use the hormone replacement therapy as primary therapy for osteoporosis, but hormone replacement does have an impact on has an impact on your bone. More recently, we've had treatments that are really focusing on helping you make more bone. They're focusing on those osteoblasts and stimulating them to lay down more bone. And those are relatively new. They've come out within the last 10 years. So several of those are parathyroid hormone analogs. That is, they're simulating the normal impact of our parathyroid glands to stimulate new bone health. The two big ones there are Forteo and Tymlos. Those are daily sub-Q injections. And then Avidity is the most recent one. That's a monthly sub-Q injection. That's, I would say, for our patients at Hershey that we know have severe osteoporosis or at risk of getting fracture, that's our first line treatment. Is typically we want to start with the anabolics, because holding you, if we know you're at risk for osteoporosis, and at one point in time the thought was, well, we'll start with the bisphosphonates, and then when you fracture, then we'll move to the anabolics. Why wait? You want to get kind of hopefully move you farther up on that scale, get more bone, and then go with the bisphosphonates or the anti-resorptive agents there. So the thing with the anabolics is that they're usually only effective for about a year. They work by changing the stimulation pathway that we have to signal to the osteoblasts that, hey, we need you to work harder and lay down more bone. And what happens over time is that signaling pathway accommodates for the effect of that drug, and then you kind of reach a new steady state. So for most part, these are only good for 1-2 years. I should also say that Avidity has also some effect on cardiovascular risk factors. So in patients that have had either stroke or have had a cardiovascular risk, they're not eligible to get Avidity, so they might go to Forteo or Tymlos kind of as your first line therapy. But I think that the recognition is that these are significant, fractures are significant events. So we're focusing more aggressively now at treating those. And I think what we're seeing is that the insurance companies, these are a lot more expensive than anabolics and our bone resorptives.
I just want to say, I have had the Avidity, and it's incredible what it does to make take you out of osteoporosis. But the side effects with that can be something also.
And these are pretty powerful medications when we're talking about these anabolics. The signaling pathway that I referenced, kind of talking about with Avidity to make you need more bone, has impact on other tissues in your body. So these are, and that's one of the reasons I think people are a little hesitant at first using them as first-line treatment. But I think kind of in patients that we know are at high risk, the risk-benefit ratio justifies being aggressive and using some more of these anabolics initially. Typically what will happen is you'll be on a year, 2 years, and then you put on an anti-resorptive agent to hold you at that state. And then after about a year or two, what the newer literature is suggesting is you can go back onto the anabolics, because now your body's accommodating to this new state where I haven't had the effect of this medication. And then you can get secondary benefit from going back on the anabolics. Probably not as strong as the first time you've had it, but kind of keeping you, the goal is to kind of keep you in a state where you're going to be at lower fracture risk.
Vitamin D, if you take it on its own, is that good? And what's that little 3 for vitamin D3? What's that mean?
Yeah, so there's different states of vitamin D, and D3 is the active one. So yeah, almost all of these patients are going to be on vitamin D. We'll measure vitamin D, measure calcium levels. And we'll talk about some of the other things that you can kind of do, but certainly the nutritional state, so having adequate calcium and vitamin D is really important.
So on the Avidity, they test your parathyroid
Yeah.
to see that it is,
That you're not hypoparathyroid. Because if that's one of the things that you're looking for is, if you might have an underlying metabolic reason why you're not. So we do that pretty much for anybody with significant osteoporosis.
on any drugs?
Yeah. Anybody with osteoporosis, as far as if they have established or severe osteoporosis,
Yeah.
will be worked up with a metabolic profile, looking at what their risk would be. So we look at parathyroid hormone, we look at your vitamin D, all those levels as well. So I mentioned the osteoporosis gap, and this kind of gets back to why are we not treating more aggressively, and why are we not, as a healthcare system, not taking, I would say taking this pretty significant health condition more seriously. I mentioned, what we're seeing is that there's wide variation between providers and health systems. So in some health systems, I'd say probably in the U.S., Kaiser does probably the best job of anybody, partly because it's a captured audience in there, but it can be anywhere from 25% to 85% of patients with osteoporosis not being treated. Unfortunately, I'd say the 85% is the more typical thing when you look across the country. A couple reasons for that. One is we're seeing more patients with osteoporosis. So it's simply the prevalence of the disease is outstripping, I think, some of the awareness and resources we use for managing that. Kind of around 2010 when we started to get a lot of reporting about these atypical fractures and osteoporosis with bisphosphonates, scared a lot of people off from taking these medications. Say, I have no symptoms, I'm feeling perfectly healthy, you're giving me a medication that's going to cause my jaw to die and my hips to fracture, why would I do that? So there was this fear of the side effects from that. A lot of people said osteoporosis is asymptomatic. So that you tend to think of, if it affects somebody else, it doesn't affect me. And so there's an underestimation of the risks coming from radicular fractures. And I think one of the other big ones is the fragmentation of our care team. Nobody really owns osteoporosis from a provider standpoint. So, for example, you come in with your hip fracture, you get your hip replacement by your orthopedic surgeon. He says, oh, by the way, I think you have osteoporosis, you probably should get treated for that. But they're typically not the one to manage it, because if I treated your hip fracture, you're going to go off now to your primary care doc or something. If I start managing your osteoporosis, then every year you're coming back to visit me, and suddenly my clinic is filled with all these people with osteoporosis that don't need a hip replacement or don't need orthopedic surgery. So they're kind of in the wrong clinic. The primary care physicians, I think they're screening for multiple other things as well. Osteoporosis is another one that falls into it, so I think it kind of falls through that care gap. There are certain populations, I think, like rheumatoid patients get managed with their osteoporosis typically by the rheumatologists. Patients with hypoparathyroidism get managed by their endocrinologist. So it's very fragmented. It's kind of what we've been looking at, how do we set up a program within Penn State Health that encompasses the entire large population of patients at risk for osteoporosis? How do we select out of those patients that are really high risk, that need subspecialty care for that? And so we have a metabolic bone disease clinic that patients can get referred to, where we have providers that are have a lot of expertise in osteoporosis. But that population there isn't large enough. The demand for it is so high that it quickly swamps. You try to treat everybody with a subspecialist, it swamps that out. So what we're looking at is saying, how do we develop a large primary care network? One, increase awareness of it, identify patients that are at risk, do that type of screening, and then get them on the appropriate treatments. And so you kind of need this ability to escalate patients, making sure that everybody's getting screened. But those that can be treated with standard bisphosphonate therapy, they're not currently at risk for fractures, but they're at risk for further bone loss, that they're getting managed in one setting in a standardized process. They're getting their regular DEXA monitoring. That those that had fractures or need more aggressive treatment are going to the appropriate subspecialists that sort of manage their care. And that's kind of what this fully integrated program is that you need. And I'd say there's, I've been a little, more of an editorial comment, but I've been a little underwhelmed by the healthcare payers' focus on this. This is talked early on about the impact that this has on healthcare costs. A lot of times the problems you have with screening studies is that from a payer standpoint, it says, I'm going to screen that patient now, put them on treatment that I'm paying for to avoid somebody else's cost 20 or 30 years down the road. From a business standpoint, so it doesn't make sense. The thing with osteoporosis is that risk of getting a fracture occurs within 6 months to a year. So what we're trying to tell the payers is that we really need to understand and identify our patients with osteoporosis. We need to treat them, not only the right thing for the patient, but from the standpoint of you as a payer, appropriate treatment here avoids a lot of costs in the relatively short term. We know that if we can treat our patients, they have up to a 30% decrease in risk if they're on simple anti-resorptive therapies. We went back and looked at our populations from that had fragility fractures in 2010 versus those that treated and weren't treated. And there was about a 30% drop in secondary fragility fractures in that population in 2 years. So there are effective treatments on this that actually work well. So I think kind of why are we not treating it? I think there's a couple things. One is there's a patient standpoint. They're asymptomatic. There's a fear of treatment. There's a lack of awareness of how important bone health is in your overall health. And from a provider standpoint, there is kind of this fragmentation that leads to these care gaps. These patients that really need to be managed and monitored like you would other significant chronic diseases. This was a meta-study that went through and looked at why are patients reluctant to get treated for their osteoporosis, and what is the overall awareness or health literacy around osteoporosis. So a couple themes that kind of came out of this meta-analysis. One is that most patients aren't aware of the risk of osteoporosis. They understand this condition of osteoporosis and what it is, but they don't really understand what are the risk factors, what are the risk factors as they relate to me, what can be done from prevention and diagnosis. Oftentimes it's thought of, this is inevitable. You get older, your bones get weaker, you get a fracture. And there is that element, but there are treatments then to change that risk. I think particularly now with the anabolics, there's ways to kind of aggressively address some of those risks. There's a misconception about what causes osteoporosis. They thought that it's related to stress and other things. They recognize that fractures are painful, but it's not serious. It's not like a heart attack or breast cancer. We're not going to die from it. Well, the fact is, oftentimes it is a factor that leads to death. Talk about the concern that patients have about side effects of their medication. And then there's an overall lack of information in healthcare providers. I'm responsible for training medical students. We have in their whole entire curriculum, I think, 2 lectures on osteoporosis. So there's most patients are not aware. It's usually like the last week of their second year, when they're thinking about, here's what I'm going to do next year. Oh, by the way, there's a lecture on osteoporosis. So I think there's a general lack of information, not only amongst patients, but among healthcare providers on osteoporosis. So what can you do to reduce your risk for fragility fractures? And this comes from the National Osteoporosis Foundation. And that's a really good website if you want to go and learn more about osteoporosis. I recommend going there. One is what we've just talked about here, understand your risk. Kind of taking those calculators, plugging in those numbers, kind of figuring out what your risk is, looking at your family history, looking at your own fracture history on there. Because you might find that, wow, I didn't realize I've had these fragility fractures. I have established osteoporosis and I'm not being treated for it. Looking at your diet. You want diets that are high in dairy, vitamin D, and calcium, so dairy, fruit, and vegetables. The recommendation is that your calcium intake be 1,200 milligrams per day, You may get up to 1,000 units of vitamin D. Diet usually does that, but particularly in patients that, as we're working up for osteoporosis, have low vitamin D levels, we'll do significant augmentation of their vitamin D up to 50,000 units a week to kind of get that vitamin D back up there. Looking at exercise, so particularly load-bearing, strength-bearing exercises, so that's strength training, walking, things that are going to stimulate your bone, putting stress on your bones is good. Looking at reducing your risk of fragility fractures, so that oftentimes is falls. So in the elderly, making sure that you're appropriately hydrated, that you pick up the throw rugs on your, that you look for that loose board that's there, make sure that you have handlebars in the showers, all these things that reduce risk. I mean, you could argue it's not the osteoporosis that causes the fractures, the fall on the osteoporosis that causes the fractures. So one of the other things to look at is to reduce fall risks, really tied into this. Things that you should quit, like quit smoking, because you know that smoking is not only bad for your bones, bad for a lot of other things. And then looking at the alcohol intake. So generally the recommendations, most of these were based on that look at moderate alcohol consumption. So that's 2 drinks per day for women, 3 drinks for men. Higher than that is when we start to see, at least in the studies that we've looked at, higher risk. There's probably some risk from lower dose, but what that is relative to some of these others is a little harder to tease out. So those are things that you can do. So just in summary, hopefully came away with is that osteoporosis and fragility fractures aren't just a minor inconvenience or inevitable impact on your life. They actually have a significant impact on the healthcare of patients, both in terms of mobility, the overall impact on lifestyle, and then also the way that they interact with other health conditions. The loss of mobility generally drives a more rapid decline in a lot of these other health conditions that we have. Really important to take action when you're young. So I mentioned the goal during your adolescent phase, it should be get enough exercise to get that bone mass as high as you possibly can get it. Fortunately, I think with the current lifestyles, we're probably doing worse now than we did 30 years ago, which doesn't bode well for what the osteoporosis risk is going to be 30, 40 years from now. And then know your risk and proactively manage your bone health. So be an advocate for yourself about osteoporosis, fragility fractures, understand kind of what your risks are, understand whether if you haven't been screened, have those conversations with your healthcare provider about and raising that discussion that can go on. A DEXA study is painless, it gives us a lot of information very quickly, and I think it tells you where you are on that curve. And so being an aware, informed patient, I think, is one of the most important things that manage an osteoporosis. So with that, I'll stop, and if there are additional questions, happy to entertain. Okay, yes.
Well, first, just a clarification. When you talked about hip fractures, are you actually saying it mostly concerns the femur?
Yes.
Okay.
Absolutely.
Okay.
Yep, so these are, and we call them hip fractures, but you're right, the hip doesn't fracture. It's the proximal femur, and it's really kind of in that femoral neck.
Okay.
And it's the ones we typically see with osteoporosis are right below the neck. On there. With certain falls, we also see in patients, fractures in the pelvis, the bone in the pelvis. They're typically non-displaced. They can be associated with osteoporosis, but the one from a clinical management standpoint is that proximal femur fracture.
I have a couple. I've heard that sometimes people fracture, then fall, instead of fall and fracture. Is that the case?
No, that's one of the things that we're never entirely sure, but some patients we think probably have such weak bones that, to get back to, it's that femur fracture that fractures just from regular weight bearing that gives out and they fall. It's always a little hard to tell, but I think that probably happens.
The second thing is with compression fractures, and if you get the kyphoplasty, do you increase the likelihood of more spinal fractures because you have such a firm hard area that you created? Is it catch-22 there?
It's a great question, and I think the answer is probably yes. So I think typically we'll do kyphoplasties for a couple things. One is it reduces pain. So a lot of patients that have had a fall and a vertebral fracture, it can be very painful. The way we treat it is we put this hot cement inside the vertebral body and kill all the nerves. So they don't feel them anymore. But to your point, while you've made this very solid piece of cement inside the weak adjacent neighbors, all you've done is shifted the force up. And so oftentimes, one of the things we look for with kyphoplasty is, what's happening to the adjacent level? Are they starting to fracture now? So, to do a kyphoplasty and not treat the patients for underlying osteoporosis is a real problem, because I think you're just simply treating a metabolic condition with a mechanical short-term. But that can happen, and it's, I would say my own personal experience, I think it happens more at what we call the thoracolumbar junction, because your spine curves right there. So when you and that's oftentimes where the forces get concentrated. So you do a kyphoplasty there, and that transfer now of forces causes fractures in the adjacent.
You're saying the lumbar?
Right at the junction of the thoracic and lumbar
Okay.
spine, right where we kind of reverse that curve.
Okay.
I always get a little, and that's where we see a lot of kyphoplasty. There's a common spot for fractures. But you always are a little concerned about the fact that you've changed the mechanics there. And so that neighbor that was previously sharing all the load with this other fracture that failed, now is having to carry the weight. So that is a risk factor. Other questions?
I think you sort of answered one of my questions there. How do you connect a replacement to a bone? I think you just touched on that. And what are replacements made out of usually?
So you're talking about hip replacements? which is most
For
common.
instance, yeah.
So typically they're going to be either titanium or stainless steel. And there's two different ways to treat it. Somebody who has very weak bones, severe osteoporosis, the way they're held in place is cement. So it's basically kind of ream out a hole in the proximal femur, you fill it with cement, and then the metal device goes in and connects with the cement, and the cement kind of integrates within those pores in the adjacent bone and holds it in place. The problem with that is over time, that typically loosens, and eventually you get failure of the hip replacement because the bone-cement interface gets weaker. Your body's an inventor, so there's this foreign body in my body, I'm going to wall it off, and it tends to lead to weakening there. And so that works fine for patients that are at risk of getting further fracture, or the bone's so weak that you can't do the other option, which is basically force a piece of metal into it that has very rough edges, and then the body grows into those rough edges. And then the nice thing with that is once it's integrated, it stays put for a longer period of time, less likely to fail. But the problem is when you're first putting it in, the bone's weak, you're putting force on the bone that may lead to a fracture. So that's the trade-off. Kind of older patient with kind of an expectation that they're not going to survive long enough to see the loosening of the bone. They're at risk for immediate fracture. I want to get them up out of bed quickly. If it's cemented, you can get back up. It's as firm as it's going to be, day one, and it would be in the future, whereas the ingrowth takes a little longer, so that there is a rehab period of limited weight bearing. So those are all the kind of considerations that go into determining what type of replacement that you might get.
Thank you.
Sure.
So is there not things called bone strength? And how do they test for that? And how does that play into this whole osteo?
So the bone strength itself we measure typically through mechanical testing on bone samples. Now we do have other things in addition to the bone mineral density that allow us to look at other features of the bone that are related to bone strength. So there's some new tests that we do that look at that architecture. I mentioned those tiny little struts there.
Yes.
And we actually can now get very high resolution images. We can look at those struts. And then what we can do is model it and say, okay, what is the strength of this bone likely to be based on that architecture? One word probably most important is in the spine. The spine typically gets a kind of a standard, we call it compression force or loading force. The force runs longitudinally along your body. And as you get osteoporosis, what happens is the struts that run crosswise across your spine, they get resorbed faster because they're not getting as much stimulation. And the ones running kind of north-south get thicker. So you end up what we call it the corduroy spine, because it looks, it's all the struts are organized like corduroy on your pants, running north and south, with nothing in between. So you might have higher bone mineral density because they're getting thicker and lighter, but you don't have those crossbars that link them together that are really important from a strength concept. So it's not just bone mineral density, although that counts for about 80% of the bone strength. There's the architecture there. Then I mentioned a little bit with the diabetes, is it's also the non-mineralized part of your bone, collagen, that gets fragile in certain conditions. And that's, we're starting to recognize that that's an important component of overall bone strength as well. So, we talk about bone mineral density as it relates to the strength of your bone, but it's probably one of the larger factors, but it doesn't explain all of the things that deal with bone strength.
How do they test for that?
So the trabecular architecture is something called trabecular scoring,
Yeah.
and that we can actually now get from DEXA studies, and then we also get it from the CT. So one of the areas I do research in is looking at patients that may come in to get a lumbar spine CT because or abdominal CT because of abdominal pain. So we get a great look at their spine, and we can actually then look at those patients that have had abdominal CT and then went on to get cap fractures. And we're doing just that. Can we use things like AI to look at the architecture and say, hey, this architecture and this bone mineral density means that this patient's at risk for getting a hip fracture down the road. So we kind of do this opportunistic screening there. Used to be that type of architecture we did. We could only do either in the distal wrist or we could do in the distal portion of your lower leg because you needed such high resolution that we couldn't do it in a regular scanner. But now the